دقيقة لأني كنت أسيف من شوي طيب أعتقد هذا صح كل اثنين هذا وهذا ها
في بايندر
هذه حركة سلايدات طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. And good afternoon everybody. I was asked to give you a subspecialty lecture today about a huge topic, which is diagnostics in glaucoma, talking about OCT, UBM, and visual field. Frankly speaking, each part of this subspecialty lecture needs 2 lectures by itself. So we'll try to make it concise as much as possible, but please bear with me, and if you have any questions, we'll leave it at the end of the presentation. So when we talk about OCT in glaucoma, why do we need it actually? We can, as a glaucoma specialist, whenever we examine the optic nerve, we have the capability of saying most of the time that this is actually glaucomatous or non-glaucomatous optic nerve head, which is true to some extent. Ideally, whenever you see an optic nerve head like this, you would go initially to look for the disc margin. Then you will look for the neuroretinal rim, and you will go for the edge of the rim, from which you will look at the residual tissue, right? Then you will estimate the cup. You will look at the lamina cribrosa depth. You will look at the configuration of the blood vessels at the optic nerve head. Then you look for the peripapillary atrophy. Then for the nerve fiber layer, looking for any defects or hemorrhages. So basically, you will be systematic. You look at the disc margin and disc diameter, neuroretinal rim, cup to disc ratio, disc size, peripapillary atrophy, RNFL defects or hemorrhages. And after doing that, you need to classify your optic nerve head, being focal, diffuse, or sclerotic. Focal tells us that actually there is an area of localized loss of the rim in superior or inferior pole, and the remaining rim is relatively well preserved in early cases, but not in advanced cases. In diffuse optic nerve head phenotype, you will have concentric enlargement of the cup with no localized loss. There will be sometimes small peripapillary atrophy, and in the sclerotic type, you will have saucerized shallow cup with pale rim and moth-eaten appearance. And there will be sometimes peripapillary atrophy surrounding the optic nerve head. Since we knew this information, what do we know now about the disc margin? We know that it's a clinical landmark defined to be the inner edge of the scleral crescent, which is the Elschnig ring, and the landmark from which the width of the rim can be measured. However, intra and inter-observer variability in detecting changes do exist. Even glaucoma specialists, when they tell you that the cup disc ratio is 0.7, when you hide their dots, they might tell you it's 0.75, 0.8. So variability do exist between subjects, or between specialists, and in the glaucoma specialist examination himself. There is also another issue, that the clinical examination is a poor method for detecting glaucomatous progression as well, unless you have a proper documentation by disc photography. So the problem with subjective optic nerve head evaluation that it depends on the examiner's experience and training. It is also affected by the difference in knowledge and characteristics of glaucomatous optic nerve head damage. It's also affected by the variability in the optic nerve head size and appearance. Even sometimes glaucoma experts might not necessarily demonstrate good intra and inter-observer agreement. And we need to know that there is a fact that structural changes sometimes precede reproducible visual field changes and vice versa. We had a gift in the early 1990s, which is called OCT, optical coherence tomography. And this gift actually was was a breakthrough in ophthalmology. So it helped us to have in vivo assessment of the optic nerve head, of the macula. And OCT actually was presented first as a time domain with low resolution and low acquisition speed. So it will take time for the patient to finish the test, 15 minutes, 20 minutes, so it's really tiring for the patient. In the early 2000s, we had something called spectral domain SD-OCT. It gives us high resolution. The resolution might reach 4 to 6 micrometer. In some research machines, it can reach 3 micrometer. So it will give you a very small cuts in the OCT scan, and you will have high acquisition speed. So you can get 40,000 A scans per second. So you can finish the test actually within 30 seconds or 1 minute sometimes if you require more data from the optic nerve head. SD-OCT enabled us as well as clinicians to perform in vivo histological analysis of the optic nerve head. It allows us to look at something called Brooks membrane opening, prelaminar tissue, lamina cribrosa, border tissue, and the internal limiting membrane. It allowed us to segment the internal limiting membrane at the cup itself and to drop a line going from the Brooks membrane opening to the other side, and thus we can estimate the cup volume. And to make things more exciting for you, if I will ask any one of you, or 2 or 3 or 10 of you, to tell me actually where is the disc margin here, or if I will bring 2 or 3 glaucoma specialists to tell me where is the disc margin, I would actually argue that we will not have the same agreement. So sometimes we will have misagreement that the disc margin might be actually external or internal to our proposed, clinically detected disc margin. So now we understand that by fact, there is no agreement on disc margin nor the rim margin. And therefore, we cannot have a proper assessment of our residual rim. And that's very important in glaucoma follow-up and progression. So what was done that IR images were taken from patients, and we have a stereo photography from of the optic nerve head. So both images were registered to each other, and the glaucoma specialists were asked to actually segment the clinically detected disc margin, and they were asked to segment the BMO, the Brooks membrane opening, on the B-scan itself taken from the SD-OCT. Both images were overlapped together, and you can see that there is actually a mismatch between our clinically detected disc margin and the SD-OCT detected BMO opening ring. You can see that in certain sectors of the optic nerve head, we have a mismatch. This mismatch might come actually temporal. It might come temporal and inferior as well. Another example, you can see here the disc margin, which is the green dots, and you can see here the Brooks membrane opening. In the previous example, we had the disc margin, the clinically detected disc margin, and the Brooks membrane opening. In the previous example as well, we have the same issue. Look at this blood vessel in the optic nerve head. So it seems that it's hanging over something. The structure which is hanging over it is actually the invisible extension of the Brooks membrane. Now remember that axons cannot actually penetrate the Brooks membrane. They need to pass till they reach the edge of the Brooks membrane, then they will go through the neural canal. So when I tell you that this is the clinically detected disc margin, and this is, and this is the SD-OCT detected true border of the neural canal, which is the Brooks membrane opening. Look at the difference here. So there is some difference, right? This difference represents your overestimation of the residual rim, and that's very crucial for us in glaucoma. So it means that sometimes, on certain occasions, we are actually overestimating our residual rim. And that's something very important for us in our clinical practice. I'll skip this example. Another example here. So we know that by fact that clinical disc margin rarely is a single anatomic entity, nor are the structures that underlay it consistent with an individual eye. So it means that whenever you look at structures at 3 o'clock geographic area, it will be not identical to those at 9 o'clock area, and structure correspond to 3 o'clock position in one eye might be different or not identical to a 3 o'clock position in another eye. Why is that? because we have different border tissue configurations present in a single eye. We have an internal oblique border tissue, and that's the appearance of the internal oblique border tissue. So looking at the optic nerve head, the border tissue goes internal. We have an internal oblique border tissue with Bruch's membrane overhang, and that's the extension of the invisible Bruch's membrane that we see. We have an externally oblique border tissue, and this is common in patients who are high myope, and we have non-oblique border tissue. So, disc margin in a clinical examination or with photograph frequently is not a true anatomic outer border of the neuroretinal rim because of the regionally variable and invisible extension of Bruch's membrane. So you can frequently overestimate your residual rim, and this raises actually an important question for us in our clinical practice. How frequent are we overestimating the rim? How frequent are we ignoring that our patient is actually progressing and we don't know that he's progressing? Now we have several facts to go to the solution. Number one, clinical disc margin is highly variable in a given eye or in between two eyes. Number two, there is a large variation in the border tissue configuration. Number three, Bruch's membrane opening represents neural canal opening through which axons pass, not Elschnig ring, not the clinically detected disc margin. And there is a large mismatch between the clinical disc margin and the Bruch's membrane opening. So sometimes Bruch's membrane opening might match the clinical disc margin, so we are safe. Sometimes Bruch's membrane opening might be internal to the clinical disc margin. We are safe, or we are not safe? Not safe. Sometimes it might be external to the clinical disc margin. It means external, you are looking at the optic nerve like this, and it's external, outside. Inside, it will go internal. This is an example as well in which an IR image was registered to the disc photo, and you can see here the mismatch between the clinically detected disc margin and the Bruch's membrane opening and the residual rim as well here. Another example in which you will have a little bit tilted disc in a high myope patient. You will have a mismatch between the clinically detected disc margin and the Bruch's membrane opening. So now we know that Bruch's membrane opening is an anatomically accurate landmark from which neuroretinal rim measurement can be made. We know that it's also a structure that is identified consistently with SD-OCT. But we still have another problem, which is that the orientation of rim tissue is variable actually around the optic nerve head. Why is that? Because axons might exit the eye almost parallel to the visual axis. Number two, axons might exit the eye almost perpendicular to the visual axis, typically in the temporal sector, which can have a shallow sloping rim, like patients who are having high myopia. طيب? So hence, potentially significant error in the rim width can occur if the measurement plane is fixed. We came with an option, or with a new parameter that would solve actually this problem, called the minimum rim width, which represents the minimum distance from the internal limiting membrane and the Bruch's membrane opening. It will overcome variable orientation of the neuroretinal rim relative to the Bruch's membrane opening. And it represents the most geometrically accurate measurement of the neuroretinal rim width. Take an example here. So you will look that you will have here an external oblique border tissue, and you have the Bruch's membrane here opening. If you take a horizontal line from the Bruch's membrane opening going to the internal limiting membrane here, and if you take the shortest distance from the internal limiting membrane here and the Bruch's membrane opening here, we will have some difference here. Actually, the difference reaches approximately 40% of the estimated rim. This assessment, which is the Bruch's membrane opening horizontal rim width, is the one that we are getting with the HRT. And this one is the one that we are getting with SD-OCT, the Bruch's membrane opening minimum rim width. So, can we actually use BMO minimum rim width in quantifying optic nerve head? The answer is yes. There are several studies that actually compared the performance of Bruch's membrane opening minimum rim width parameter with the RNFL thickness and with the Bruch's membrane opening and horizontal rim width represented by the HRT. You can see that the diagnostic performance with the BMO is higher than the RNFL, and at the bottom of the list is the measurement that we get with HRT. When you look at the global Bruch's membrane opening and MRW, the sensitivity is 81% compared with 70% that one that we get with the RNFL. And last at the bottom is the Brooks membrane opening horizontal rim width, which is the one that we get using the HRT. If you look at the sectoral assessment of the Brooks membrane opening minimum rim width along the optic nerve head, the diagnostic performance of the Brooks membrane opening minimum rim width is actually higher compared with the retinal nerve fiber layer thickness and the HRT detected rim. So now a question that will be arised, can we actually depend on SDOCT to quantify optic nerve head derived parameter because it's an automated segmentation, right? The question is, yes, we can depend on it to some extent, but the problem is that you need to revise the SDOCT scans until there is a solid improvement in the segmentation software. Why is that? Because sometimes the software might segment an external oblique border tissue as being the Brooks membrane opening like here. Sometimes it might mis-segment the ILM because of the presence of a blood vessel at the edge of the disc. Sometimes a high myope patient with external oblique border tissue will have the same error. And sometimes the machine simply cannot segment the border tissue. That's why you need to run over the machine and to look if there is a proper segmentation or not. So, should we stop clinical disc assessment? The absolute answer is no. Why is that? Because you need to know if there is peripapillary nerve fiber layer defect, in which the machine will not provide you with this information. You need to see if there is disc hemorrhage or not, and you will not get this in the SDOCT. Bowing or excavation of the optic nerve head surface will not be actually visible with this machine. And the color and health of the rim regionally or by clock hours is very important for us as well. However, should we always use SDOCT in our practice? The answer is, if you have a completely normal optic nerve head, no. But if the clinical disc examination is suspicious, then it might help us in providing an anatomically accurate assessment of the neuroretinal rim. However, you should actually correlate it with clinical examination. This is an example of the how we actually do the segmentation. So first of all, you will go and look for the 24 radial scans of the patient. Okay? So once you look for the 24 radial scans, you can actually look after that for the Brooks membrane opening. And once you look after that for the Brooks membrane, once you look for the Brooks membrane opening, then you will look for the segmentation. Is it properly segmented or not? If it's not properly segmented, then you need to double click on the BMO segmentation icon and just move the Brooks membrane opening over it here. So that represents the termination of the Brooks membrane opening. After that, you need to look for the ILM segmentation here. Just I'll bring to you one case scenario so that we will not exceed our time. 50-year-old gentleman who is myope. His refraction is 4.5, having primary open-angle glaucoma and prostaglandin analog. His IOP is 16 and his vision is 20/80, and he's complaining about dropping vision. So when you look at his disc photo here, it's reasonably acceptable. You can see that the patient is actually losing his inferior rim. And when you do his visual field examination, you will check, or you will be surprised that he's having a dense superior scotoma. That's why he's complaining. If you look at the retinal nerve fiber layer thickness in the OCT, you will see that the patient is truly having some findings or some changes. So he's having, thin rim inferiorly and the borderline rim inferiorly as well. But it doesn't explain this really dense scotoma that he's having superiorly. But when you look at the SDOCT parameters here, you will find that the patient is actually having significantly thin rim inferiorly. So that's his rim inferiorly, and that's the RNFL, and that's the minimum rim width detected by the SDOCT, and you can see that he's having a dense superior scotoma. And this will actually tell you or it will actually be an important tool for you to correlate between the severity of the visual field change and at the same time the RNFL report, if it would be of great help for you or not. So most of you now will realize that minimum rim width is an important and strong tool that should be used all the time. The answer is no. You need to use both parameters. The reason is the RNFL can detect actually early nerve fiber layer defects compared with the SDOCT sometimes in certain occasions like normal tension glaucoma patients. This is a 45-year-old lady who is having primary open-angle glaucoma and prostaglandin analogs with a vision of 20/40 and IOP of 14. And she's complaining about changes in her visual acuity. When you look at her disc photo in 2008 and disc photo in 2013, You are noticing some change here, right? So what kind of change do you see here? So this is, so it's a disc hemorrhage, right? When you look at 2015 disc photo, what do you find here? When the hemorrhage resolved? Exactly. And when you look at the 2016 disc photo, you will have some changes. So, as we said that the minimum rim width helped us before in the previous case. Why don't we try it again? When we did for this patient, the minimum rim width, we found that it was completely normal. So let's revise it again. Why it's completely normal. When we look at the nerve fiber layer defect, it was intact in 2008, but she was having a small disc hemorrhage in 2008 as well. 2012, she developed a significant another disc hemorrhage, and she was having a nerve fiber layer defect. You can see it clearly on the IR image. So there is a clinical evidence of glaucomatous disc changes. So we know by fact that patients with normal tension glaucoma, the most important clinical hints that tells you that they are progressing is disc hemorrhage, followed by enlargement of the peripapillary atrophy area. So when we did for this lady RNFL, you find that she's having actually thinning superotemporally, which is corresponding to the area of the nerve fiber layer defect. So that's the minimum rim width, and that's the RNFL report for the patient in 2012. And that's her visual field showing a corresponding inferior visual field changes. So just I'm going to skip this. So now we see that the patient is having actually progressive changes in her RNFL. So the thickness was 90 and it dropped to 75 approximately. That's why the patient was complaining about changes in her vision. And that's the disc photo showing us actually the thinning of the rim superiorly, as if you can appreciate here. That's the rim in 2008, and that's the rim in 2016. You can see the disc hemorrhage here, followed by another disc hemorrhage, nerve fiber layer defect, and the previous nerve fiber layer defect. That's the change of the rim in 2008 and 2016. So there is some significant loss. Look at the blood vessel here, and look at the blood vessel here. So the blood vessel here is still, laying on or supported by some neuroretinal rim. But here, the rim is actually narrowing with time. So over 8 years, she had some significant progression. So our take-home message is that SD-OCT is a strong, helpful tool to support our diagnosis. However, clinical assessment is still important in reaching the diagnosis for all of your patients, not only patients with normal tension glaucoma. This is another case. A 28-year-old lady who's having primary open-angle glaucoma and maximum anti-glaucoma medication. Her vision is 20/60 and the IOP is 26, and she was referred for possible glaucoma surgery. As you can see here, she's having a completely normal optic nerve head in the other eye, but advanced glaucoma in the eye which is having the open-angle glaucoma. You can see the visual field. She's having a dense superior scotoma. If you look at the visual field parameters, look at this area. When you look at the SD-OCT, printout, you will have almost 12 sectors represented: superior, inferior, nasal, and temporal. Temporal nasal. Look at the rim here. It's almost not existing at all. So she's having complete loss of the rim in this area. She's still having some rim here, and she's still having some rim here. Superiorly, there is a very narrow rim, and very narrow rim, but compared with the inferior part here, the rim is almost completely disappeared. That's why the visual field defect is mostly localized superiorly. That's the SD-OCT report of the patient, showing you the minimum rim width and the RNFL in the right eye, and the completely normal parameters, except for a borderline in the left eye. That's the OCT again for the patient. Sometimes in the printout, you might have a message like this, which is in orange color. It tells you actually that the segmentation here might not be accurate. Once you see this message, you need to go to the machine yourself and resegment the patient again. Look at the scans. You have 24 radial scans or 12 radial scans that you need to revise them and look at the error. You might have an ILM poor segmentation or BMO poor segmentation that you need to adjust. Once you adjust it, this message will disappear and you will have a completely accurate SDOCT report. So we finished our first part in the diagnostics of glaucoma, which is concerning the SDOCT. Now we'll come to the other part, visual field. So we said before that visual field is important for us. Sometimes changes in visual field might precede changes in the OCT and vice versa. So when we talk about visual field, what do we mean by it? It's actually an area perceived by a fixating eye. There are some certain limitations of our normal visual field, 60 degrees superiorly, 60 degrees nasally, depending on the nasal bridge, inferior 75 degrees, and temporal 100 to 110 degrees, but you might have some certain variabilities. Commonly in our practice, we are using the automated visual field. We have a manual visual field called Goldman visual field, right? The issue with Goldman visual field that it needs actually a skillful technician to run the machine and to explain to the patient how they will do the test. Most of the time, most of your clinical practice, you will have the automated visual field. This is a topographic representation of the eye, and this peak represents the fovea, in which it has the highest concentration of photoreceptors. So in the foveal area, logically, you will have the highest retinal sensitivity, in which dimmer targets become more visible, and the brightness of target at threshold decrease, and we'll have differential light threshold measured in apostille decrease, and the periphery away from the fovea will have the opposite readings. We have something called StatPack, which is the Humphrey field analyzer that we have in our Humphrey visual field. It will actually have the data from the patient, and it will compare it to a normative database. It uses an inner program to help in diagnosis and progression, and it will use a white-on-white strategy. So the stimulus is whitish in color, and the bowel background is whitish. That's why we call it white-on-white strategy. We'll use size 3 target, which represents 16 millimeter in area, and we have a duration of stimulus, which is 0.2, and the test distance should be 33 centimeter. Whenever you have a Humphrey visual field printout, you will have certain things that you need to look for in which you can interpret your Humphrey visual field. You need to look at the name, ID, and age, which is a very important thing for us. Why? Name is essential so that you will not mismatch your patients together, or you mix patients together. ID is important as well. You have patients sometimes who are having the identical first, middle, and last name. And the age is very important as well. Why is that? Because the machine will actually compare the patient age that you entered to a normative database. So if you change the patient age from being 18 to 28, you will have sometimes a wrong reading, or a wrong parameters that were compared to a normative database. We have the type of test that will be shown to you superiorly in the visual field printout. We have some different protocols. We have 10-2, 24-2, and 30-2. Some might ask, why do we have -2? Why don't we have -1? Actually, there is a protocol called -1. But the issue is -1 that it will give us actually test points directly on the horizontal and vertical axis. So that's the horizontal, and that's the vertical axis. And it will be difficult for you to interpret these results. That's why we commonly use Protocol 2, or 10-2, 24-2, and 30-2 strategies. So Protocol 2 will test points on either side of the horizontal and vertical axis, and defects found right on the line can be difficult to interpret. That's why we will move it to the Protocol 2. Now, what's the difference between 30-2, 24-2, and 10-2? Actually, when you look at the 30-2, you will discover that actually we are testing 76 points, but we are having a wider field tested. 24-2, we are testing 54 points, smaller field. And 10-2, we are actually checking the inner 10 degrees, which represented by 68 points. So if you have 10 degrees tested, and you have 68 points within this 10 degrees tested. So we are doing a lot of tests in this small 10 degrees. So that's why 10-2 is giving us actually a magnified image of the macular area and the juxtafoveal area. That's why 10-2 is being used for patients with advanced glaucoma. Patients who are having tunnel vision, and you follow them up with 24-2, you will not actually appreciate some changes that they are having. But if you do the 10-2, you are testing more points within a smaller area. So you are testing 68 points. So any changes within those patients who are having advanced glaucoma will be picked up by the 10-2, but unfortunately sometimes not by the 24-2. Now, we are checking actually 1 degree away from the vertical and horizontal axis and 3 degrees away on the 30 and 24-2. And whenever you test 1 point away from the vertical and horizontal axis, after that, the distance between one spot and the other will be 6 degrees in the 24 and 30-2, and then it will be 2 degrees in the 10-2. That's why, again, the 10 visual field is a more magnified, give us a more magnified representation of the patient condition, especially in patients who are having advanced glaucoma. We have different strategies in the printout that you will be seeing here. We have the full threshold and the fastback and the CETA standard, or sorry, the CETA, which is the Swedish interactive threshold algorithm. You have CETA standard and CETA fast. Most of our practice in glaucoma clinic, we use the CETA standard. I might skip this for the sake of time. In the printout, you need to look for the treatment used, and you need as well to look for the pupil diameter. This is very important for us in glaucoma clinic because sometimes you might find patients who are started on pilocarpine, for example. You initially saw the patient in the clinic and you offered him a treatment. You gave him pilocarpine. His pupil diameter was 5 millimeter or 4 millimeter, and he came to the follow-up with a pupil diameter of 2.5 millimeter or 2 millimeter. So this by itself can induce a defect, and you will think that your patient, especially if he's having advanced glaucoma, you will think actually that the patient is progressing, although his visual field is, or sorry, his IOP is normal. So please pay attention for the pupil diameter. 3 millimeter and more is an acceptable pupil diameter to interpret the visual field changes. Sometimes we can agree that 2.5 millimeter will be acceptable if you have it on the patient's initial presentation. So that's why we need to stress on the point that repeat tests should have similar pupil diameter. You might accept a 0.5 millimeter change in extreme conditions. In the printout, you will have in the upper left quadrant something called the reliability indices: fixation loss, false positive, and false negative. What will happen in fixation loss? Now, what the machine does is that when you stay or when you fix actually your patient chin and then ask him to look at the fixating target in the bowel, the machine will give you a stimulus, which is a light stimulus, and it will give you a sound with it. Okay? And the machine as well will try to map the blind spot. And how does it actually map the blind spot? It will send a stimulus toward the optic nerve, right? So every now and then during the test, the machine will send a stimulus to the blind spot, to the optic nerve. If the patient responds to it, what does it mean? It means that the patient is not fixating, right? We can accept a fixation loss up to 20%. More than that, we could, actually question the reliability of the visual field test. However, some patients will have an enlargement of their blind spots. Like what? Exactly, and patients with advanced glaucoma. So we can accept sometimes up to 30% in such condition, patients who are having, for example, advanced glaucoma. Another reliability indices is the false positives. So we said before that the machine will actually give you a stimulus of light and it will give you a sound. So what will happen in false positive? The patient will press the button to noise, but there is no actual stimulus. So the patient is trigger happy. And sometimes if the patient actually press the button for more than, let's say, if the test was done, or if the patient, or if the machine actually tested for false positives 20 times, what's the percentage of the acceptable, false positive that you would consider to be within normal limits? So let's say 20. You will accept up to 30%, 30, 33% sometimes. So out of 20, how much you will accept? 6 stimuli, 7 stimuli sometimes. So that's regarding the false positive. False negative, what does it mean? So when you present a stimulus to the patient, and the stimulus is of, let's say, 20 decibel. By the way, when I give you a stimulus of 5 decibel and 30 decibel, which is stronger? 5. 5 is brighter. Right? So if I present to a patient a stimulus at location Z, for example, and this stimulus is 20 decibel, then I gave him again a stimulus after a while, and this stimulus is 10 decibel. So I gave him 20, then I gave him 10. So the 10 is brighter or dimmer? It's brighter. So if the patient doesn't see the 10, this is labeled as false negative. It doesn't make sense that the patient saw a 20 decibel stimulus and did not see a 10 decibel stimulus at the same location. Another important thing, talking about the reliability indices, or just we'll catch it later. So the Humphrey visual field will project a stimulus at 9 decibel brighter than that was seen earlier in the test. And one of the justifications for having a high false negative is that the patient will be tired of the test. He will be fatigued, or lack of concentration, or sometimes severe retinal disease. And you can accept up to 33% or less. Before going to the grayscale, there is something down here called the fovea. Please make sure before you do the interpretation of your visual field printout that the fovea is on. Why is that? Because it doesn't make sense that the foveal threshold sensitivity is 30 and some point at the periphery is 40, right? Your area of maximum vision is the fovea. So always ask the technician to keep the fovea on. If it's off, you will have fovea off. It will be written here, fovea, then off. If it's on, you will have the fovea and there is a number beneath it. So ideally, in common conditions, you will have the fovea of, or you will have actually the threshold sensitivity in the fovea being higher than the other places, except areas of scarring, exactly. Another thing in the printout that is usually helpful for you to explain to your patients what he's having and what kind of disease is affecting his visual field is the grayscale, which will give us a graphic representation of recorded threshold sensitivity in the numeric scale. And it will give us the regions of decreased sensitivity, which are displayed in variable colors. The more darker the coloration of the grayscale, it will tell us that actually the patient is having more advanced loss in this particular area. And it's very useful for displaying pattern of loss being actually glaucomatous or neurological defects. Numeric scale, again, it will give us graphic retinal sensitivities at different test locations expressed in decibels, as you can see here. And we have then an important part in the printout, which is called the total deviation. Now, what do we mean by total deviation? It will tell us actually the threshold sensitivity. The machine will take this threshold sensitivity and it will compare it to the normative database. And it will give us a numbers, either being 0, it tells us that the patient is having no difference from his age-matched population, or it will be in positive, so the patient is doing better than his age-matched population, or negative, so that the patient is doing worse than his age-matched peers population. So we have another thing called pattern deviation, and it's very important for us. So why do we have total deviation and why do we have pattern deviation? What's the function of pattern deviation? Pattern deviation will emanate the possibility of media opacity. طيب. Then we have glaucoma hemifield test, in which it will actually take 5 zones superiorly and 5 zones inferiorly, and it will compare the changes in each zone superiorly in its image mirror zone inferiorly, and it will tell you that either these changes are within normal limits, or it's borderline, or it's outside normal limit. And then we have mean deviation and pattern standard deviation, which are the most important thing for us. The mean deviation represents actually the overall depression or deviation from normal values of the field. All the values of the tests are added and divided on the number of test locations, and it will tell us the difference between the two values represented as a mean deviation. So mean deviation might indicate that the patient is having an overall depression, like cases of, again, cataract. Or it can tell us that there is actually a significant loss in one part of the field compared to the other, like patients with glaucoma or patients with scar, patients who are having scar or retinopathy. So keep in mind that mean deviation will tell you the deviation of the patient from his peers. So it will give you the height. So it might indicate that the patient is having an overall depression or very significant loss, as we mentioned before, in one part. And we can use actually the mean deviation to tell us about the severity of the disease once we correlate it with the pattern standard deviation. So a mean deviation of -2 up to less than or equal -6 will tell us that the patient is having mild visual field change. -6 up to -12, moderate, and -12 and more is severe visual field change. So look at the visual field, sorry, at the mean deviation here. We mentioned before that it will tell us about the height, not the shape of the visual field. And that's a mild change, that's a moderate change, and that's a severe change, giving that the patient is actually having glaucomatous disc damage. Pattern standard deviation will measure the degree to which the shape of the patient measured field departs from the normal age-corrected reference field. So low pattern standard deviation will indicate a smooth hill of vision. High pattern standard deviation will indicate an irregular hill, which commonly we see in patients who are having glaucoma. So just I'm going to skip this. So how would you describe visual field changes? It's very important actually to comment on visual field changes in certain aspects. Number one, most common early presentations that we have in our clinic is a nasal step. Number two is a superior scotoma or arcuate scotoma. Number three is a paracentral scotoma. Number four is a paracentral scotoma, which is threatening fixation. Number five, dense superior scotoma. Number six is tunnel vision. That's something called Garwe-Heath map. And that's very important for you to know it and memorize it, because the beauty about the Garwe-Heath map, and that now there is an adjusted map based on the 4D axis, or the location of the fovea in correlation with the geometric axis of the optic nerve head. The importance about the Garwe-Heath map that it can tell you actually, or it can predict for you, the future visual field damage that could affect actually the patient's vision or the patient, daily activity. For example, so that's the patient who is having a superior scotoma, right? When you look at the optic nerve head here, the most significant area of thinned neuroretinal rim is superior or inferior? So inferior. When you look at the Garwe-Heath map, you look at this zone. So it represents to us a yellowish and a reddish zone, which in the visual field will be superior. That's the reddish and that's the yellowish zone. So, and it's actually correlates nicely here with the visual field printout. So once you see a patient, you examine a patient in your clinic, and you follow him up, and you find that the patient is having progressive thinning inferiorly, you can predict in the future that the patient will have a superior scotoma. Once this, thinning progress, let's say temporally, inferotemporally, you will realize that this area is jeopardized, and this area represents this reddish zone here, and it's near to fixation. So that's why it's important for us to memorize the Garwe-Heath map, because it will tell us about the future of the patient, the expected, future of the patient regarding his vision and his daily activity. Once fixation is threatened or the visual field change reaches fixation, the patient will have a phenomenon called split fixation. Have you heard about split fixation? Once the patient had split fixation, his vision will drop significantly, right? So that's the importance about the Garwe-Heath map and its predictability for the patient future visual field changes. So to conclude the visual field part, whenever you are confronted with a visual field printout, you need to wonder so that you can read the visual field. So once you wonder, you will ask yourself, you need to wonder. Number one, W stands for what was done. Number two, A, is it accurate or not? Number three, N, is it normal or abnormal in general? Number four, the defect pattern. Number five, the E stands for the evaluation for compatible disease. And the R will go for number six, which is the revision of your printout. So let's start with one test here. So that's a printout or a visual field that was done for a patient. Number one, we will ask ourselves, what was done? So here we have a visual field test, which is a 24-2 CETA standard threshold test, which is white over white. Pupil diameter is there. I'm sorry, it's small. So it's 4.4 millimeter. So now we understand what was done. So now we will go for A. Is it accurate or not? We will go for the reliability indices. So when you look at the fixation loss here, it's 0/16. So fixation loss is safe. Then we will go for the false positive. So it's 0. it's less than 30%. Then we'll go for the false negative, 3%, less than 30%. So, and the fovea is on, it's 36 decibel, or 35 decibels, sorry. So now we finished W from the wonder, what was done, it's a 24-2 visual field. Then we went for the A, is it accurate or not? Now we'll go for the N, is it normal or abnormal? Looking at the grayscale, we realize that actually this patient is having abnormal visual field. طيب? Then we will look at the D. So the D stands for what? The defect pattern. So you look at the mean or the total deviation, then you look at the pattern deviation. So the changes are still there. So what kind of defect pattern we are having here? It's a scotoma. So let's agree on one thing. This is a scotoma, right? Is it superior or inferior? So it's a superior scotoma. Look at this vertical and horizontal axis. Is it near fixation or away from fixation? So it's beneath fixation actually, right? So we finished the D. Now we'll go to E. So E is what? Evaluate for compatible disease. So what kind of disease that will produce for you a superior scotoma, threatening fixation? Glaucoma. So once you go here for your disc photo, look at the superior rim, inferior rim. What kind of thinning that the patient is having, in which area? Inferior. So inferior changes will produce, changes in the reddish and yellowish zone, which is corresponding to the superior area. So now the patient started to develop these changes. So in future, these changes might progress more and more because the thinning is inferior, right? So that will tell you that if you don't act fast, the patient might come with full involvement of this superior zone. So he might have dense superior scotoma. Now, once we finish these things, how would I rank my glaucoma patient? What kind of damage he's having? Now, the mean deviation here is minus 3. And the pattern standard deviation is 7. So the pattern standard deviation is more than 2. It's 7. Why is that? Because you have irregularities of the patient visual field health. So one area is significantly damaged, other areas are normal. So there is a significant dip here. So that's why the pattern standard deviation is high. طيب? So having a mean deviation of minus 3, it will tell us that the patient is having mild, moderate, or severe glaucoma. Mild. But taking into consideration the visual field damage shape, this patient needs special attention. So the mean deviation numbers that we are getting are important, yes, but don't rely on them, but pay more attention for the shape of the visual field defect that you are having. Another example here, another visual field printout here. As we said before, we'll look at the reliability indices, and before that we will ask ourselves what was done. So we'll go for the W, what was done. What was done is a 24-2 CETA standard, then we'll go for the reliability indices. Zero fixation loss, false positive and false negatives are less than 30%, right? But look at the false negative here, 20%. Would it tell you something? 20%, would it tell you something? No, false negative. What does it tell you? Or look at the eye gaze tracker here. Exactly. So the patient is not paying more attention for the test. طيب? Sometimes he's disturbed. So you can actually look at the gaze tracker here and it will give you some information about the patient performance. So when we look at the reliability indices, it's normal, it's fine for us. We looked actually at the age, it's the same age, same ID, same pupil diameter. Then we will go for the defect, right? So we looked if it's normal or not, it's abnormal. We go for the defect, we have dense superior scotoma, and here it's dense. On the pattern deviation, it's dense superior scotoma. When we go for the mean deviation, how much is it? Minus 10. So mild, moderate, or severe? Moderate. Look at the pattern standard deviation. It's 12, right? So because why? There is a huge discrepancy in the visual field in the superior and inferior sectors. This is another example, but look at the pattern standard deviation here. It's 11, right? And here it's 12. It's higher. Why is that? So why do we have a higher pattern standard deviation here compared with a pattern standard deviation here in a patient who's having almost tunnel vision? Exactly. Because the shape of the visual field is generally suppressed. So this patient is having far advanced visual field damage, right? And that's why we're having very high mean deviation, which is minus 18, and that's a severe glaucoma, although the mean deviation is higher than the pattern standard deviation. The last part of our subspecialty lecture is the UBM, or ultrasound by microscopy. We have only 10 minutes to conclude. I'm sorry for this, but that's the assigned time for us. Whenever we talk about ultrasound by microscopy, we need to realize that we have different size of probes. We have 35 up to 80 megahertz, and this will play a role in the resolution. The higher the megahertz that you have, 80 megahertz will give us a better resolution of 25, followed by the 50, followed by the 35, and that's very well known for you. One of the good things about the UBM, or the most important things about UBM, that you need something to give you good depth and high resolution. However, UBM is limited for the depth penetration. So it will go up to the level of pars plicata, right? Or pars plana. Whenever you look at the UBM, you need to know the structures that you are looking at. So here you have the cornea. You have the corneal epithelium, which is shiny here. Desmet and endothelium. You have the anterior chamber. You have the anterior lens capsule, and you have the lens. And when you look at the angle, you will have some certain structures. You have the cornea, you have the sclera, you have the anterior chamber angle, and that radio-opaque area is an important anatomic landmark, which is called scleral spur. You have the ciliary body, and that's the normal orientation of the ciliary body. You have the posterior chamber, you have the lens capsule, and we have the zonules attached here. Now, the utilization for UBM will be for evaluation of the angle, anterior chamber depth in case of dense corneal scar, posterior chamber depth, corneal thickness sometimes, iris thickness, configuration and insertion, ciliary body thickness, scleral thickness, IOL thickness, and but it cannot evaluate for us the lens thickness because of what? The poor penetration. So whenever you look at the UBM, you need to realize, or you need to actually memorize the normal configuration of the angle. So as we mentioned before, radio-opaque area here represents scleral spur. And that's the angle, and that's the normal shape of the iris. It's laying flat. You have the ciliary body here. You have the opening here behind the iris and bounded by the ciliary body called the sulcus, or the posterior chamber. Whenever you have an anteriorly bowing iris, it will tell you that the patient is having what? Pupillary block. So when the patient is having a posteriorly bowing iris, it comes to us in cases of what? Pigmentary glaucoma. Why is that? Or pigment dispersion. Why is that? Because the patient is having high pressure in the anterior chamber compared with the posterior chamber. That's why the iris is bowing posteriorly. It can actually help you to evaluate the presence of peripheral anterior synechia. You can see that here the scleral spur, and there is no space between the scleral spur and the iris. Why is that? You can see that the iris is attached to the cornea because of the presence of peripheral anterior synechia. So look at the normal angle configuration, and look at the angle here. Look at the scleral spur here, and look at the iris insertion, and look at the angle here recess. And look at the scleral spur here, and look at the presumed angle recess, and look at the iris. It's inserting at an area anterior to the scleral spur. This is another example showing us closed angle with anterior bowing of the iris, pupillary block, and that's after YAG peripheral iridotomy. You can see that the anterior bowing of the iris is relieved by the peripheral iridotomy. Again, you need to see the anatomic landmarks. That's what? The scleral spur, and that's the iris. That's the posterior chamber. And you can see here in patients who are having intermittent or pupillary block, for example, that the space of the posterior chamber or the sulcus is widened or enlarged here. Another example of patients who are having plateau iris with anterior ciliary body. Look at the ciliary body forwarding anteriorly here, and look at the normal position of the ciliary body here. Sorry, of the ciliary body here. So compare it with this one. So it's coming more anterior. It's occupying more space here, right? So that's a condition of plateau iris. You might have plateau iris with closed angle and plateau iris with open angle after iridoplasty. Look at the angle recess. It's widened now after iridoplasty. In plateau iris, you will have sometimes thickening of the iris stroma. طيب. That's a normal angle again, and that's an angle recession. In angle recession, what is this? Scleral spur. And what's this space? Exactly. So what will happen in angle recession, that you will have two things: widening of the ciliary body face, and that's the ciliary body, and that's the scleral spur. You are supposed to have the iris insertion here, right? So the ciliary body is widely exposed, and you will have posterior displacement of the iris scleral insertion. That's why a huge part of the ciliary body is exposed here. That's a normal angle again, and that's an area of cyclodialysis cleft. What will happen in cyclodialysis cleft? You will have separation of the ciliary body from its normal location at the scleral spur. So fluids will pass freely from the anterior chamber to the supraciliary space. That's why you have hypotony sometimes. And that's the free communication from the anterior chamber to the supraciliary space. So you have here the ciliary body, it's detached from the scleral spur, and that's in case of cyclodialysis cleft. UBM can help you as well to evaluate the presence of iridodialysis in patients who are having corneal scar, for example, and that's disinsertion of the iris from its roots. It can show you sometimes an area of zonular dialysis in case that the patient is having significant corneal edema or poor visualization, or in cases like microspherophakia, for example, for academic purposes. Again, that's another image of cyclodialysis cleft, and it will show you the detachment of the ciliary body from its normal location at the scleral spur. And here you can see actually ciliocoroidal effusion. It's important in conditions of what? Ciliocoroidal effusion. Aqueous misdirection, to differentiate it from what? Aqueous misdirection. Right? Annular, you might have sometimes patients with post-combined or post-trabeculectomy, for example. He's having a pressure of 20, 25, and you are not sure if this is an early stage aqueous misdirection or annular ciliocoroidal effusion. What will happen is that the ciliary body will be edematous, it will be large, and it will be filled with fluids. You will have some fluid vacuoles here, right? You will have separation from the sclera. You see that this is the supraciliary space, and that's the separation from the sclera. And you will have translucent supraciliary fluid. If you don't have a translucent supraciliary fluid, then this will be what? Hemorrhage. Hemorrhage. If you have a separation, but you don't have a translucent fluid, what will it be? Blood. Hemorrhage. طيب. Again, look at the normal UBM here, and look at the UBM here. So you are not supposed to have a supraciliary space which is empty like this. You are supposed to have the ciliary body attached to the sclera. So that's the ciliary body attached to the sclera, and that's the separation between the ciliary body and the sclera because of the presence of supraciliary fluid. Another example, I'll just conclude with this slide. This is a case of aqueous misdirection. Look at when you look at cases of aqueous misdirection, you need to be systematic. Look at the anterior chamber depth. So here the anterior chamber is very deep. That's number one. Number two, look at the angle and the angle recess. The angle is completely disappeared here. So that's the second criteria. Number three, you need to look at the ciliary body. So where is the ciliary body here? It's rotated anteriorly. Why is that? Because it's forced by the aqueous itself. طيب. So we'll have an anteriorly rotated ciliary body, and sometimes on certain occasions, because of the surrounded inflammation, you might have fluid in the supraciliary space, such as in this condition, which is very translucent. I think I will stop at this point because we are having a grand round after that. Thank you very much for your attention, and I really apologize for having so much of information. ها؟ ما يعطيني 3 لكشر في لكشر واحدة. لا.
3 أيام.
محمد.
فين يا عم؟
هنا.
هلا عبد الله
تحطها هنا.
حبيبي.
كيف حالك؟ طيب.
فيصل فين يا فيصل؟
البروجكت حنغيره شويه، حنعمل فيه موديفيكيشن شويه.
طيب وش الموديفيكيشن؟
انت شايف يمكن هناك.
برسل لك اياها واتساب بالاكسل فايل.
خلاص ما هي مشكله.
وبرسل لك ايميل عشان ترجع. اذا في شيء موديفيكيشن نو بروبلم، اي كان دو ات اني تايم.
طيب
بس عشان يكون عندك ايديا وش انا ماشي عليه.
خلاص ما هي مشكله.
زين.
الداتا المفروض ان ناخذها من السيرفر. شفت ساره اللي بالوار؟
ايه.
خليها تعطيك لسته عن الاي سي بي كيسز دم. تعطيك اياها ابتداء من 2015 وقبل كذا ناخذها من البوك. احنا بدينا بالاي سي بي عام 2013 تقريبا.
من الفايل.
ايه لا في بوكس.
في بوك.
او ار بوك 2013 14 15 تقدر تجمعها.
كلها بالفايلز.
ايه بس ما هو بالبوك تبعي انا، البوك اللي في الاو ار، اللوج بوك تبع الاو ار. انت بكره وش عندك؟
بكره كلينيك الصباح مع الدكتوره نوره والظهر مع دكتور حاني.
يمكن كاتش من بتوين كلينكس. مر علي بس
بالأو. كاتش ماي سيلف بكره. انا وش
اجي خلي الخميس نشتغل. الخميس عندي.
اللي على الصباح بكون مع الدكتوره نوره تجيب البيشنت حق الصباح. والظهر
اجل
الخميس كل داي كلينيك مع الدكتور معلم. يكون 45 بيشنت.
اجل خلي اكلمك بكره المساء.
خلاص.
خل تواصل معنا بكره المساء. خلاص ما هي مشكله. ستارت. ها؟ عم خليهم يلتقطون انفاسهم. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته جميعا. And welcome to the weekly joint academic activity in King Khalid Specialist Hospital. Whenever we talk about stress in life, so many things raise in your mind. So you have social stress, you have professional stress, exam stress, examiner stress, Dr. Isam stress, and so on. So stress do exist in our medical field, especially in ophthalmology. I believe that they did a study before, and in that study they looked at the number of physicians actually who are thinking about suicide or committing suicide. So ophthalmology was among the upper list. So congratulations. So when we talk about stress, we need somebody to talk about stress and to tell us how to cope with stress. Stress comes in multiple levels. So whenever you come to the clinic, you are stressed in the morning. Whenever you go to the OR, you are stressed. Whenever the patient comes to your clinic, he is stressed as well. So there are multiple levels of stress, and the best person that I know who could talk about stress in ophthalmology and stress in glaucoma per se is Professor Isam Uthman. So Professor Isam.
Thanks, Dr. Faisal. Bismillah ar-Rahman ar-Rahim. So what will come in your mind when we talk about glaucoma stress? So everybody will think according to his interest. If you are working genetic lab, Luckily, we have Dr. Altaf, chief of our genetic lab today. So what will come to his mind that will talk about glucomatous stress. And definitely our glaucoma specialist here, not all in the pictures, but they will think about complications. So what about the patient? If you are a glaucoma patient, so definitely no one else can feel your pain and suffering. Glaucoma is a neurodegenerative disorder due to injury of retinal ganglion cell. This is the definition according to European Glaucoma Society. Definitely manifested by visual field change, and intraocular pressure is just risk factor. And when there is imbalance between the pro-survival and the pro-death protein, we know that there is BAX protein and BCL protein in mitochondria. When there is imbalance between them, there will be release of vasomediators, and this is actually what happened and what we call it apoptosis. Still, the best name for glaucoma is Swerick disease, as we know. And diagnosis depend on our slit lamp examination, intraocular pressure measurement, and the gonioscopy is very important to know what subtype of glaucoma you are dealing with. And you are lucky today to take this imaging with Dr. Faisal today about OCT, visual field, and UBM. Treatment options available: medical therapy, laser treatment and ultrasound, as well as surgical interventions. So glaucomatous stress, we'll talk about first glaucoma oxidative stress. We know that oxidative stress leads to structural changes of the cell wall and obstructs the process of maturation within the cellular structure. And this will lead to the following: cytoskeletal damage, protein oxidation, DNA damage, inactivation of enzymes, release of cation from intracellular stores, and chemotaxis. And as we know that the metabolism of oxygen in the retina lead to what we call it reactive oxygen species. For healthy retina, we should have reactive oxygen species in very low level, not high level. And this low level of reactive oxygen species is very important to maintain the function, proliferation, host defense, signal transduction, and gene expression. So however, reactive oxygen species can also be dangerous when it is in high level. This excess quantity of this will lead to retinal ganglion cell death. Under normal condition, cells are able to balance the production of oxidant and antioxidant. Oxidative stress occurs when there is imbalance in our cells due to either increase in free radicals or decrease in antioxidant. And this is definitely what will happen when you have imbalance. There will be oxidative damage in form of tissue injury, inflammation, and apoptosis. And you can see that the vascular and mechanical theory can be explained by formation of reactive oxygen species. The vascular theory is based on ischemia-induced production of reactive oxygen species due to compromised blood vessel in retinal vessels, blood flow in retinal vessels. The mechanical theory, mechanical pressure theory, for formation of reactive oxygen species involves elevated intraocular pressure, inhibiting the retrograde neurotrophin support for retinal ganglion cell axons. For both mechanisms, retinal ganglion cells die due to oxidative stress. The oxidative stress has been implicated to cause increased intraocular pressure by triggering the trabecular meshwork degeneration and thus contributing to alteration in aqueous outflow pathway. So increased intraocular pressure and visual field damage have been found significantly related to the amount of oxidative DNA damage affecting the trabecular meshwork. So the antioxidant delay or prevent oxidation of a substrate and reduce the reactive oxygen species, and definitely the imbalance between the pro-oxidative and antioxidant capacity will leading to oxidative stress affecting multiple signal cascade have also been postulated. So how to evaluate the reactive oxygen species? Actually, by measuring the level of TAS in plasma, the total antioxidant status. And this is the studies correlated the total antioxidant status to glaucoma stress and the glaucoma patient in Saudi cohort in our studies in King Abdulaziz University Hospital. This is the first study published in Saudi Medical Journal, association of total antioxidant level with glaucoma subtype and severity. This is actually 340 glaucoma patient in a case control study. Plasma sample were collected between September 2013 to October 2014. The highest number of patients was primary open angle glaucoma, 147, pseudoexfoliation glaucoma, 54 patients, and angle closure glaucoma, 139. And the control of matching gender, ethnicity, and 5 different comorbidity also studied. And you can see the result here. When we measure the TAS in this different type of glaucoma, we find that it's statistically significant in primary open angle glaucoma and pseudoexfoliation type, but it was not statistically significant related to the angle closure glaucoma in relation to control samples. Then we study different type of glaucoma separate. This is another study in current eye research, decreased total antioxidant in patients with primary open angle glaucoma. This is 139 primary open angle glaucoma to 148 control. The mean test level was significantly lower among the primary open angle glaucoma than the control. And it shows that test level show trend towards reduction with increased severity of glaucoma, presented in a very significant association with cup disc ratio. So what we find here that the high cup disc ratio is inversely correlated with TAS, and this indicates the severity of anti-glaucoma medications, anti-glaucoma type, primary open angle glaucoma. The other study, we studied the total TAS correlated to intraocular pressure in patients with angle closure glaucoma. And as I mentioned before, it was not statistically significant, but there were inverse correlation between test level and IOP. And you can see here that the test level was significant, inversely correlation to intraocular pressure in primary open. This is the next study in molecular vision, decreased total antioxidant status in plasma patient with pseudoexfoliation glaucoma. Again, 54 patients to control. It was statistically significant, suggests that TAS may have an important role in pathogenesis of pseudoexfoliation glaucoma. To summarize, the glaucoma oxidative stress, our studies provide evidence that total plasma TAS level are decreased in patients with glaucoma, more in open angle pseudoexfoliation, less than but not statistically significant in angle closure glaucoma. This finding supports the hypothesis that decreased antioxidant defense or increased oxidative stress may have a critical role in pathogenesis of glaucoma. I know this is difficult to digest, but let us go and relax for other things. Glaucoma patient stress. What glaucoma patient stress? We know that the glaucoma patient either have chronic glaucoma or acute glaucoma. Both of them are suffering. Let us start with the chronic glaucoma. The chronic rise of intraocular pressure will lead to function loss, as discussed in visual field function, and this will lead definitely to stress. This is a very interesting study in ophthalmology. The aim of this study to explore patient perception of vision loss in glaucoma, especially to test the hypothesis that patients don't recognize their impairment as black tunnel. All of us believe that glaucoma patients see black tunnel or black particles. So in this study, it was interview, 3 questions were given. How does glaucoma affect your vision? Are you aware of your visual field defect? How does glaucoma looks and how does it impact on your daily life? They show the patient, 50 patients, 6 images. 50 patients share in this study, mean age of 70 years, and the mean deviation of the best eye was minus 7 decibel. So the main outcome, forced choice of image best representing glaucoma vision impairment. And this is the unmodified image on your right side. On the left, this is the black tunnel. This shows the patient all these pictures and to choose what he is suffering, what he is seeing. This is the Blair tunnel. The previous was black tunnel. This is the Blair tunnel. And this is the black patches, sorry. And this is the blurred patches and the missing parts. The result, as you can see, away from what we are believing, that the missing part, the blurred particle or parts and the missing parts were more than what we are believe that black tunnel and the black parts was common. So patient with glaucoma doesn't see black areas and the most don't have tunnel vision. Important to insist situation of raising awareness of glaucoma detection and patient education and actually to let us feeling of patient suffering. What about acute rise of intraocular pressure? So definitely we can control the blood pressure, but sometimes we are not able to get the intraocular pressure down in some cases. So example of this condition, every day we are receiving a case of neovascular glaucoma in spite of diabetic retinopathy prevention and all the interventions and all the efforts done by our retina colleague, even in campus, to get the diabetic patient early and treat them early. We are still receiving, I think you will agree with me, that on daily basis we are receiving cases of neovascular glaucoma. And the patient is suffering. And we are suffering also because we cannot treat the patient on the same day. We cannot finish his problem in one day. And you see what Duke Elder mentioned in 1969, that inoculation is the only practical treatment. Grants mentioned in 1974 that there is no mean are known to prevent neovascular glaucoma. And Hoskin mentioned that the treatment is disheartening. That the clinical presentation, as we know, presented with severe pain, semi-dilated pupil, intraocular pressure usually above 40, rubeous irides, new vessel in the angle, and all this is the manifestations. And what Phalangal mentioned, when you ablate the retina and ablate the new vessel in the angle, you will change the case from a neovascular glaucoma to chronic angle closure glaucoma, in which any filtration surgery will help the patient. But what is the problem? This is the main treatment. It should be rule for all patients of neovascular glaucoma, atropine, breathhold, full medications, as well as starting PRP plus minus Avastin. So what is the problem? Why patient is suffering? We will never get the pressure much down as we expect in neovascular glaucoma. We will never get the pressure down. So we need time between the attack of neovascular glaucoma until you have intervention, and we need to stop patient suffering in this period. This is the problem. Patient is still in a pain for about 1 week between the retina and the glaucoma, given some injections in his eye, and he is suffering. And you cannot get the pressure down, especially some of them, they are renal patient, cardiac patient. You are even unable to give them systemic medications. Angle closure glaucoma, simple. You always come to emergency, and the majority of cases are responding to systemic diamoxistat, beta blocker, followed by bilocarbine, and you can do the laser YAG iridotomy in emergency. As this patient presented with bilateral angle closure glaucoma after hyperopic laser correction to emergency, and they managed nicely by laser iridotomy. But not always the condition is like that. We received one lady with neurofibromatosis. She presented with bilateral angle closure glaucoma in the same week, and the PI is not working. Even we are not able to do the PI for her because of thickness of the iris. And it ended by trabeculectomy both eyes. Retinal detachment repair, patient is suffering. Sometimes they came in wheelchair, they have renal failure, diabetic, high intraocular pressure, and sometimes difficult even to put them to examine them in slit lamp. Phacoemorphic glaucoma, another entity of terrible type of glaucoma. Usually, you have inflamed eye. You start with systemic diamox, Bredt-Fort, beta blocker, and brimonidine. Laser iridotomy not always done well, or sometimes difficult to do. You should get the IOP down by all means, and don't be in a hurry for surgery in these cases because the eye is severely inflamed. Your plan should be in mind, depend on the duration of attack, gonioscopy, and the medications. And definitely the definite treatment is cataract surgery plus minus glaucoma surgery. Post-BKB glaucoma, terrible, and we should look for gonioscopy in these cases to know exactly what is the reason behind the high intraocular pressure, the angle closure or steroid-induced glaucoma. Uveitic glaucoma, take care and don't have a false economy of not giving the proper dose of steroid to inhibit the inflammation because you are afraid that the patient will get high intraocular pressure because of the steroid. And definitely treatment is available in form of medical therapy as well as surgical intervention. And take care that cyclophotocoagulation, there is question mark about done this in uveitic patient. So how to release pain for patient? This patient came with acute attack. You are not able to treat him in the same day to finish his problem. So we should think as a glaucoma specialist about something to release. This is an example, very nice, interesting. You can see one of our retina people are doing what he's doing? Paracentesis. This is good. Sometimes release the pain for patient, but unfortunately this is temporary. So what we should do, the patient neovascular glaucoma take 1 week at least to interfere. Some cases also came with uveitic with high pressure. You are not able to operate because you should give at least 3 days intravenous steroid. So we should think about something, have gradual decompression of this pressure for patient. It should be temporary in form of corneal valve. This is just thinking, this is not creation. Like that. Something to release in a chronic way to release patient stress. Now, we'll go to glaucoma specialist stress. This is relaxation before you go to stress. The glaucoma specialist stress, I think all of us share in these problems. Sometimes the problems become operative and sometimes post-operative. Let us share some stories. This is 30 years ago when I was working in south of Saudi Arabia, and their senior consultant now, they were resident at that time to King Saud Fellowship Outreach Program. I think you know most of them. This is one case there, 95 years old male, pseudo-exfoliation glaucoma. His vision was 20/100. Alhamdulillah, he's not single eye patient. Other eye was good and controlled on medication. He has high intraocular pressure and advanced disc damage. The plan at that time was to do triple procedure. There is no phaco at that time. I was assistant to that surgery. So trabeculectomy, ECC, BCIL was done. Surgery went very nicely until we put the intraocular lens. Then suddenly the red reflex changed and we closed all the wound. And we consult the senior at that time. We called the senior, he came and explored the wound. He was not thinking that this is something dangerous. And he opened the wound and expulsive hemorrhage occurred and patient lost his vision. So if you expect suprachoroidal hemorrhage, close, and plus minus drainage. This is another patient. It was Mongolism mosaic form, 14 years old female with juvenile glaucoma, high intraocular pressure with disc damage. We did for her non-penetrating glaucoma surgery with viscocanalostomy. Second day of surgery, she presented with pressure of 14, clear cornea, and deep anterior chamber. This is 1 week after surgery. She presented with severe corneal edema, and at that time, even we don't have OCT. We did for her UBM show total descent membrane detachment. Patient is not good cooperative. She is Mongolism. We took her to the OR, and we inject SF6 gas 15% to anterior chamber. Second day on slit lamp, we find that the air not injected in anterior chamber. We find that the air injected between the descemet membrane and the cornea. It was a problem to take the patient again to theater, and the patient is not that cooperatively, but we did trial that on slit lamp. I put the needle and aspirate the air between the descemet and the cornea, and I push the needle again, inject to anterior chamber, and luckily it succeeded. This is the patient after 2 weeks, and this is the patient after 1 month, and it is published in International Ophthalmology, I think, as benefit of ultrasound in management of total descemet membrane detachment. This is another case in which 55 years old male with intraocular pressure of 35, and he has light perception. He was diagnosed at advanced open-angle glaucoma end stage on full topical medication, so we decided to do for him trabecutomy. So trabecutomy done for him. The first post-op, he was 0 pressure, flat anterior chamber. UBM done for him, it showed cerebrochoroidal effusion and cerebrochoroidal and cyclodialysis cleft. And actually, most of time he has still shallow anterior chamber, not formed well. But patient, because he presented with light perception, he didn't make any problem for us. This is another patient, uveitic patient, 46 years old male, with vision 20/60, intraocular pressure was 40 on full medication, advanced damaged disc, immature cataract. So we plan to do trap phaco for this patient after well preparation by retina team. So post-op, the patient presented 8 o'clock in the morning with 20/30 vision. Patient was very happy. Intraocular pressure is 12, and eyes almost quiet. So what happened? At 6 o'clock, patient presented to emergency with hand motion and endophthalmitis. So what he did, this patient? Actually, patient left the hospital happy. He went to his company and roaming here and there outside until he developed pain. He presented to the hospital. So we call retina team, lovely early intervention and saves the eye, and the patient end with vision of 20/60. So here, what is the problem? Usually we advise rest after surgery. Patient should be sitting in a good atmosphere, and don't tell your patient after, especially phaco, we are telling a patient after phaco, go do what you like. Bend, do anything. This is actually not, from my side, this is not good because I see the bad things. Definitely maybe patient will not develop anything, but why not to stay at home? Why not to stay quiet in good atmosphere? This is another patient presented to me with pseudoexfoliation glaucoma, 31 millimeter mercury intraocular pressure, immature cataract, and subtotal cupping. Actually, this patient presented with hand motion. So the plan was trap phaco. The post-op intraocular pressure was 11. Bleb was not leak. The eye was quiet, and the patient vision improved to counting finger 2 meter. After 2 weeks, IOP raised to 21 millimeter mercury. So I decided to do suture lysis for him and subconjugal injection of mitomycin. Massage of the bleb done, and during massage, severe bleeding occur. I cannot stop. I batch him 3-4 times. I wait for him 45 minutes in the clinic. The bleeding is not stop. After 1 hour of batching, he has subtotal hyphema. So double batch was done. 2/3 of AC was with blood. And after 1 week, blood completely absorbed. Intraocular pressure is 10. Formed bleb 10 millimeter mercury IOP. So if no massage and suture lysis done for this patient, when the pressure raised after trap, the surgery will fail. So you should take the risk. You should be in stress 1 week to solve the problem of this patient. UCB, this is the patient just we did it in the last Eid holiday, before Eid holiday. 62 years old female, high intraocular pressure on maximum medication. Actually, she has multiple glaucoma surgery before, and there is no space to do surgery, so I decided to do for her just cycloplasty ultrasound. So what happened to this patient? Post-op pressure is 14, very nice, on 2 medications. Then after 1 week, the patient presented to emergency room. I was on call at that time in Eid holiday. And I was on ER at the time she come, luckily, with decreased vision, intraocular pressure is 3, flat anterior chamber. There is no anterior chamber at all. It was a surprise for me. Then B scan was done, flat retina. We don't have UAM in emergency, and no visible choroidal. Then I observed that patient one day. I put her on atropine and Bradford. The second day she came, still flat anterior chamber. Then I took her to OR and I formed the anterior chamber. So this is little stories from big stories. All of us, maybe you have more stories about stress as a glaucoma, but my advice today is that to decrease the stress, you should have informed consent, discuss the case nicely with the patient and family, especially family member. Sometimes the patient will fight by family member understand. CTR for certain cases between your colleagues should not hide the complications. Take opinion of other doctor-patient relationship is very important. I have acknowledged to Dr. Yasser Al-Fiqhi who gave me the title of this lecture, and thanks for Dr. Altaf from Genetic Lab and Dr. Ihab, he gave me the jokes. Thank you very much.
Thank you very much, Professor Isam, for this very nice lecture, and I'll open the floor for any questions. So any questions, please?
Or sharing problems, stress.
Thank you, Prof. Isam, for touching this unusual topic to be explored and talked about. I just need to say something that we need to acknowledge, all of us, that we are, as a medical doctor, supposed to have some sort of stress, starting from the medical school until the practicing the either ophthalmology or other specialty. And that stress is sometimes positive for us for improvement and for progression. Just I want to alert some people, if they having the stress exceeding what is they're capable to do, they need to sort it out. Because if you leave that stress growing with you, that may affect your performance and affect the patient safety and affect your end results. So usually we are under exploring this part of our, even in our training of the resident and fellows. So if you are, as a medical doctor, noticing this point of stress and trying and seeing your performance is not as good and that is building up, you need to take off sometimes and try to manage that either with the colleagues from other specialty or from counseling other people to solve this. Because if you leave it, that will be a burning out for you. And that will change based on specialty. And we know maybe you guys in the glaucoma having the worst, but I think all the specialty have sort of challenging cases and sometimes stress, either from the work or from even the administration, from the work, from the even social stress sometimes.
Thank you, Dr. Abdullah. I agree with you definitely.
Thank you, Professor. I would just stress on one point that you mentioned, the last slide and the last word you mentioned, doctor-patient relationship. I think this is the most important factor in the clinic. So if you have to explain to the patients, even the patients that sometimes you see elderly patients, you might say in your mind, you're not understand what I'm saying, but you have to simplify it to the extent that he understands what you're going to do, what we're going to expect from these operations. So I think most of the problem coming between the patient and the doctors, I think this relationship is not built in a good way.
I give you example, the first case I present 30 years back when the patient lost his vision. He talked to me next day. He tell why you are upset. The patient is asking me why I am upset. You can believe that? I like to start the quiz, then we go for Salah and to continue quiz and the morbidity and mortality count. So please don't go.
Just a reminder that we are conducting a flu vaccine, please. Those who didn't have any vaccination for the flu this year, they should have it. It's part of the Ministry of Health direction. And it's mandatory for the resident fellow and the physician. All the paramedics.
There is vaccination outside, please.
Yeah.
If flu vaccination, if anyone interested, he can take this outside.
It's not interested, Assam. It's mandatory.
Not interested?
No, mandatory.
You are protected?
We are going to keep this booth
Mandatory.
for vaccination for the next few weeks. I mean, if somebody missed the vaccination because of the crowdness today, he could do it next week or the week after.
Please let us start the quiz before, then we can go for Salah and come for answer of quiz and to continue. The answer after prayer. Just take the question now. This is the first question. 88 years old hyperopic female presented with left eye pain associated with blurred vision, headache, nausea, and vomiting. The patient had a history of cataract extraction with intraocular lens implantation. Again, this is female presented with severe eye pain, headache, nausea, vomiting. She had history of phacoemulsification, cataract extraction with intraocular lens implantation. So from the picture you can see what is your diagnosis. What is the diagnosis? This is question number 1. Question number 2, the management guideline, يعني the steps of management. Guideline, that means steps of management. Number 1, this is a female presented again with severe pain, headache, nausea, vomiting in her left eye, and she has a past history of cataract surgery with intraocular lens implantation. The first question divided into A and B. A, what is diagnosis? B, guideline or steps of management. كلير يا شباب، نخش على اللي بعده. If you know the diagnosis, very easy, you can tell I did this, that. Second question, 69 years old woman presented to clinic with decreased vision in her left eye with high intraocular pressure. You can see this is the photography. So what is first, what is your diagnosis from the picture you see? And give me 2 clinical signs. So the left eye have intraocular pressure is high. What is the diagnosis of this condition? And give me 2 clinical signs. Picture is clear, slit lamp is clear. Very clear here, yeah. Not clear? قربي تعالي. ها زياد. I think the picture is very clear here. At least you can see what happened in the cornea, what is in the iris. Very clear. So diagnosis, 2 clinical signs. You can get even 3 clinical signs. Finish يا شباب. شايفين الارو pointed to something here. The arrow pointed to something. This is one of the clinical signs. Yes. Iris. Third question. 24 years old Caucasian man presented with complaint of transient blurring of vision with rainbow colored halos around the light with pressure sensation. The refraction is myopic refraction. Has it clear ولا ما clear? Very clear. So the number 1, the diagnosis. Number 1, you should write the diagnosis. What is this type? What is diagnosis here? Number 2, in slide A. You can see slide A here. A هنا, A down. In slide A, give me what is this sign, what you call this sign. Clear هنا ولا ما هي واضحة؟ And slide B, what is this red arrow pointed to what? شايفين السهم الأحمر ده ولا ما باين؟ ها؟ So what is here also? So what is diagnosis? Slide A, what is the sign? What you call this sign? Slide B, what you call this sign also? What you call this? Actually, this is gonioscopy picture. So what is here in line, in this red line? هو طبعا الصورتين مبينين الارو الريد. So you can see here, you can see here. If you are not able to see one of them. حد واجد صعوبة في بي؟ على فكرة في صورة ثالثة ليها كمان. If you are not seeing, there is another picture here. في 3 صور لنفس الليجن اللي احنا عايزين تقول وات از ذس. ده رأيك. ما تفتل الناس تقول لهم كلام تلخبطهم. هذا طارق، ما هي في الكورنيا يا طارق، حرام عليك. هذه في الكورنيا يا طارق؟ ما شاء الله جابتها. There is history of glaucoma trabeculectomy surgery 2 weeks ago and the intraocular pressure increased. From this picture, what is your diagnosis? And again, what is your management? 2 weeks after trabeculectomy, you have this picture. What is diagnosis? What is the treatment? سهلة دي ها؟ History of glaucoma surgery, trap. Diagnosis, treatment. Very simple. آخر question. هي ملهاش شوف اللي عارف، هي كلمة واحدة. الإجابة كلمة واحدة. What is happened 2 weeks after trap? High IOP. From the picture, diagnosis is treatment that. Number 1 spot diagnosis. الكويستشن ده فيه 3 حاجات. spot diagnosis. شايفين what spot diagnosis here؟ spot diagnosis. طبعا ما تفكرش في الجلوكوما، فكر في حاجة تانية. spot diagnosis. طيب نمبر 2 هنا معلش مكتوبة 3. type of glaucoma may develop in this patient. look to this picture, what type of glaucoma may develop in this patient and what is the cause of glaucoma. يبقى number one, spot diagnosis. What is diagnosis here? Very easy. Number two, according to this slide, what type of glaucoma this patient may develop and what is the cause of glaucoma in this patient. يا جماعة الصلاة ماكسيمم ربع ساعة، 15 minutes هنديكوا، هنرجع هنا إن شاء الله كام؟ يبقى 3 وكام؟ هنعيد 3 و10، 3 و10 عشان هنبدأ الأنسر والموربيديتي ومورتاليتي. هنعيد الأسئلة تاني سريعا. ادي الفيرست كويستشن. انت اي سؤال؟ الاولاني، هذا البيشن عامل كاتراك سيرجري بريزنتد ويز نوزيا فوميتنج بين. يعني ايه؟ الحين وات از ذا دايجنوزز؟ شوف الصوره الاولى والثانيه، اعتمد على اي واحده فيهم وات ايفر يو لايك. diagnosis والجايد لاين اوف مانجمنت. السؤال الثاني decrease vision in the left eye patient present to clinic and this is the pictures. في كورنيا بيكشر، في ايرس بيكشر، في عايزين الدايجنوزز وتو كلينيكال ساين. نراجع السؤال ده تاني خلاص. التاني السؤال الثالث what is diagnosis of this case؟ myopic patient Caucasian 24 years myopic. خلاص الدياجنوزس سهل. ساين A ساين B ريد ارو ساين B. سلايد A what is this sign وسلايد B طبعا B محطوطة 3 مرات، ادي واحدة وادي الثانية والثالثة. what is this what you call this sign؟ وهنشوف مين اللي هيجاوبها. محدش يفتح الموبايل انا عارف. history of glaucoma surgery 2 weeks presented with high intraocular pressure. diagnosis treatment. كلمة واحدة في كل حاجة. diagnosis treatment. حد بقى يساعدنا يلم الورق. second slide. خلاص يا محمد. third slide. Fourth, high intraocular pressure after surgery. diagnosis treatment. آخر سلايد spot diagnosis. تاني حاجة what type of glaucoma may develop and what is the cause of glaucoma. مين هيساعدنا يجيب الانسر؟ 15 minutes for صلاة and come back. رأيكم؟ عايزين هاتوا الورق الأول، هات الورق. يا نايف مجموعتك كده انت لم الورق. who will answer the first question. خلاص يا جماعة الورق اتلم. نايف حطه هنا كده. Who will answer the first question? لجين. طالما جايه من الاي ار يعني فريش يعني. Who want to answer the first question? ايمان كويس. استني بس استنى معاه الورق لسه، هو بيكتب، هيكتب وراكي. So patient with high IOP with shallow anterior chamber. احنا بنقسم طبعا الشالو anterior chamber after surgery لحاجتين. shallow AC with high pressure, shallow AC with low pressure. Your diagnosis is, so she diagnosed aqueous misdirection. What other differential diagnosis of shallow AC with high pressure? طب why not suprachoroidal hemorrhage؟ لا not could be. لو قلت could be يبقى كده اجابتك زيرو خلاص. لو قلت could be in this picture has against your answer. ليه؟ لا كلكم excellent. شوف الدكتوره ارفعي ايدك. excellent because there is BI. احنا ليش حاطين اللي سالنا؟ انت ليش حاطط السلايد الثانيه؟ if there is patent BI seen to me this rule out suprachoroidal. بيوبيلر بلوك كنت تشوف ايه في اليونيفورميتي؟ ما تكونش بيبقى في حاجه اسمها ايرس بومبي. فيري جود. يبقى ده الديفرنشال دايجنوز حاج البوست اوب هاي اي او بي ويز شالو اي سي. بي اي والرول اوت بيوبيلر بلوك. بيوبيلر بلوك سوري. بيوبيلر بلوك سوري بيوبيلر بلوك. هنا طبعا الريد ريفلكس مهم جدا if there is no red reflex. Yeah, but most likely after 2 weeks نعم hyperopic patient so most likely this is aqueous misdirection. حد جاوب حاجة غير الايكوس misdirection يرفع ايده. جاوبت ايه؟ ها؟ طيب يلا مين يجاوب السؤال الثاني؟ هذا difficult شوية. طارق لا نيوفاسكولار. اكسلنت. انا اعتقد ما هيجاوبوا كتير. طبعا انتوا شايفين كوجان ريز، يعني شايفين هنا you can see this one. لا باين المابيليشن حق النيفاي مالتيبل نيفاي كوجان ريز سندروم. يبقى this is ice يا جماعه. what is the signs؟ لا كوجان ريز. وايه تاني الساين التاني؟ لا you forget also the corneal decompensation not edema decompensation. يلا مين هيجاوب الثالث؟ مين اللي هيجاوب يلا يا حمد. في الجون يا حمد. طب ما تقول بيجمنتري جلوكوما، يعني بيقول لك بريزنتد ويز كذا كذا. ها ايش رايك؟ نمشي الاثنين ولا نخليها؟ تمشي. طيب ساين ايه؟ ممتاز. الساين بي بقى مين عرفه؟ اكسلنت يا ايمان. ها يسموها ايه؟ ايمان جابتها ايه؟ شيز ايه؟ شي ايه؟ لا سترايب. شي سترايب. هذه بتبقى ايش اللي بيحصل؟ some people tell the same but this is mainly شي سترايب. ايه اللي بيحصل؟ liberation of this pigment بتمشي مع الزنيول friction of the zoniole to the posterior surface of the iris. يقوم يروح البيجمنت تقف على exactly when the zoniole is attached to the equator of the lens capsule. مين هيجاوب هنا؟ اتفضل. very good. فأي مريض يجيب high pressure injected bleb raised after surgery this is encapsulation. treatment ريليز ازاي يعني؟ ايه ريليز؟ هتهز كده؟ بيقول ريليز. يا اخي اتكلم علمي حتى. هتحركها؟ ايش الكلام؟ في حاجه اسمها باينيدل، في كلام علمي يتقال. وات يو كول ات يو ميك. اسمها نيدلينج مش هزه. نيدلينج اند very important if you do needling and you don't do subconjunctival injection ولا كأنك سويت شيء. طبعا ودي البينيفيت اوف meticulous follow up of patient after surgery انك تشوف after 1 week after 2 to 3 weeks عشان الانكابسوليشن. هذا سبوت دايجنوزس نمبر ايه. حد جاوب حاجه غير توزز؟ وتوزز واضح العين الليفت فيها توزز يا لوجين، صح؟ اللي طبعا كتب ميكانيكال توزز ياخد فول مارك، اللي كتب توزز ياخد نص درجه. لان لما تشوف الصوره الثانيه، الصوره الثانيه دي عباره عن ايه؟ كابل ستون بابيلي تعمل ميكانيكال توزز، فاللي يكتب ميكانيكال توزز ده بيرفكت انسر. طيب وات از ذا تايب اوف جلوكوما كان ديفلوب؟ عايزين بقى حد من الجينيور مش من السينيور يقول لي واي هاو ات كوز جلوكوما. جينيور ما شاء الله. maybe the senior don't know. يلا صلوا يا جماعه و10 minutes وتيجوا بقى. اشيل انا بقى وانت جهازي. ها مش واضحه
كلنا ظاهرة
مش واضحه. ايه يا عم ظاهر؟
يعطيك العافيه.
تسلم يا حبيبي. ايه الاخبار؟ عجبتكم الاستريس ولا؟
يعطيك الف عافية.
ها؟ الناس تخاف تتكلم على
بروف تميز
يعني ربع ساعة يعني ربع ما شاء الله قلت هو ترى فلسفة كثيرة بس هذه كيف صح وين
وش هو السوبر كلايد الهيمرين؟
لا هي صراحة أنا نيفا أنت برا قاعدة ما يشتغل يعني
رايك ابدا انا اخلص بسرعه؟
والله اللي بدك. انت كم سلايد عندك؟
انا عندي
انا ما ادري لا اتوقع اكثر من 20 بشوي.
ان شاء الله ما راح.
خلاص اوكي صارت. وش هي طب الحال؟ والله يعني بس it's important يعني.
بسم الله الرحمن الرحيم.
start huh?
السلام عليكم. Good afternoon all.
يلا يا شباب يا شباب يلا يا شباب. هي جت هنا؟ النادي بره تيجي جوه. خلصتي ولا لسه؟ ها؟ لا دي ما حطيتش اسمها بتقول. هنعرف اللي ما حطيتش اسمها تبقى فلان. خلاص هم حرين.
والله أنا يمكن ما حطيت اسمي ترى ونسيت.
لا هي السكرتيرة بعدين تروح للسكرتيرة.
طيب خلاص ما طيب بسم الله الرحمن الرحيم. I'm going to talk about a morbidity case, and first thanks to Prof. Isam for giving me the opportunity to present this case. And this photo presented here in this slide is taken from a study that is published more than 35 years ago, and it is actually a fluorescein angiography of the iris, which shows in the early frame in your left side an early hyperfluorescence at the pupillary border, which increases in size and in intensity in late frames in your right side, which might give you a hint of the morbidity case. So the outlines of this presentation is, first we'll talk about the case, and then we'll do a brief literature review, and then finally conclusion. So my patient is a 72-year-old male presented to the business clinic in King Abdulaziz University Hospital. He is known to have diabetes mellitus and hypertension for many years, and he has a history of cataract surgery in the right eye 6 months prior to his presentation and still following elsewhere. He has a history of retinal laser, as per him, multiple sessions within the last 1 month, no history of injections. He presented on Alphagan, Tubradix, cyclopentolate, complaining of persistent pain and blurry vision in the right eye for 1 week. On examination, his VA is hand motion. His IEP is 50 millimeters of mercury. He had a mild corneal edema, in the eyes. He's zoodophilic with 0.7 cup to disc ratio. Retina examination confirmed by a retina specialist concluded proliferative diabetic retinopathy, ischemic retina, no PRP scars. So the initial management or the initial plan of the patient was topical and systemic anti-glaucoma medications, topical steroids and atropine, antivascular endothelial growth factors, in which paracentesis was performed by the retina specialists, and pan-retinal photocoagulation. And of note, the patient didn't afford the price of the treatment, and thus he was transferred to the ophthalmology ER to be admitted and then to continue management through the ER. Now, in the 2 days later after the treatment and the injection, the IEP was 29, the cornea is clearer. However, the AC is extremely shallow. The rubiosis is regressing, flat posterior pole with fresh PRP scars. Now, the question is, what is the cause of this extremely shallow AC? We were thinking about coledochoroidal detachment, and this was proven by ultrasound by microscopy. And what do you see here in this area? So this is a fluid in supraciliary space, which happens in cases of coledochoroidal detachment.
But what is the cause?
Now, what is the cause of this? What do you think? Now, the patient, from the history, and paracentesis was done, and pan-retinal photocoagulation was done. Okay. So actually, it is more of paracentesis, because the paracentesis was done and the eye was more hypotenuse for.
Actually, when we come to see the patient, he has very extreme shallow anterior chamber. Then I advise to do UBM. Then the retina team, I met them, they tell we just do paracentesis for this. So it was the reason of mainly paracentesis, not because of extensive BRP.
So the plan was to observe the patient, and 1 day later, the IUP is 19 on topical and systemic anti-glaucoma medications. The cornea is clear, the AC is deeper, regressed NVIs, flat posterior pole with fresh PRP scars, and the plan was to do tube surgery or external CPC. However, the tube was not available at that time in the hospital, and thus the plan was external cytophotocoagulation.
Till today, not tube in the hospital.
شلون؟
Till now.
إلى الحين؟
Not tube, yes.
Okay.
1 month now. I don't know what.
طيب. 1 day post cyclophotocoagulation, the patient is having 12 millimeters of mercury IOP with no medications. The cornea is clear and the EZ is deep. Now, going to the literature review. Neovascular glaucoma, as you all know, is a severe type of secondary glaucoma. It can be an open angle or closed angle glaucoma, as we will mention later. There are three major risk factors for neovascular glaucoma, and the most common and the most important is ischemia, followed by inflammation, followed by tumors. And if you not enumerate the causes of neovascular glaucoma, you will have many causes. However, they can be retinal ischemic diseases, as we have mentioned, surgically induced tumors, radiation, inflammatory diseases, and even miscellaneous causes. In our patient, diabetes and cataract extraction were the main risk factors for developing neovascularization and subsequent neovascular glaucoma. Now, the main mediator in neovascular glaucoma is vascular endothelial growth factor, and it was previously known as vascular permeability factor, and it is basically a signal protein that is produced by some cells, which we'll mention in the next slide. VEGF is a subfamily of growth factors. They are both involved in vasculogenesis and angiogenesis. Vasculogenesis is the formation, the de novo formation of blood vessels in the embryonic circulatory system, while angiogenesis is the formation of blood vessels from a pre-existing blood vessels. And there are 5 major classes of VEGF. They include VEGF-A, which is the most famous and has multiple isoforms, and it is involved in the angiogenesis of the vascular endothelium, and it can increase permeability, and it is also a pro-inflammatory factor. VEGF type B is involved in the embryonic vasculature of the myocardial tissue. VEGF type C and D, they are involved in lymph angiogenesis. Placental growth factors is involved in vasculogenesis and angiogenesis. And from the classes and description here, you can see that VEGF type A and placental growth factor are the main mediators that are targeted by antivascular endothelial growth factors. Now, the cells that produce VEGF in the retina include RPE, vascular endothelial cells, retinal neurons, pericytes, smaller cells, astrocytes, and even ciliary epithelium. And under normal condition, VEGF functions to maintain the health of the choriocapillaris and also to protect the retinal neurons from apoptosis, and this was proven in animal models that chronic VEGF inhibition can lead to significant loss of the retinal ganglion cells. And thus VEGF is required in a certain level that is largely controlled by the pigment epithelium derived factor. Now, going back to antivascular endothelial growth factor, in 2004, pegaptinib was manufactured, and it blocks only, or it binds to only one isoform of VEGF type A. 1 year later, bevacizumab was manufactured, and till now, it is not FDA approved. And the difference that is, it binds to all isoforms of VEGF type A. Ranibizumab in 2006, it shows higher affinity than bevacizumab. And in 2011, aflipercept was manufactured, and it binds to all isoforms with higher affinity. In addition, it binds to placental growth factor. And under phase 3 trial, maybe you have heard about brolucizumab, which shows a higher affinity and extended duration of action. Now, going back to neovascular glaucoma, there are 3 types or 3 stages, as you know. The first stage is NVIs or NVAs without glaucoma. The second stage, the patient will develop open angle neovascular glaucoma, and this open angle can progress rapidly in a zip-like fashion to close the angle as in stage 3. The clinical evaluation of patients with neovascular glaucoma includes, as any clinical entity, history, examination, and investigations. In the history, the patient might be asymptomatic in early stages. However, the patient can complain of the symptoms of high intraocular pressure. You have to ask about history of PRP. When was the last PRP? How many sessions? Intravitreal injections. How many injections? In which eye? When was the last injection? Systemic diseases are very important in reaching the etiology of the neovascular glaucoma. Ocular surgeries, ocular trauma, medications, including drop systemic medications, and medications allergy. Clinical examination ideally would include vital signs, in addition to the visual acuity, intraocular pressure, pupil examination, confrontation visual field, a slit lamp examination of the anterior segment with gonioscopy if the view allows, dilated fundus examination, and disc assessment. And depending on your history and exam, you can proceed for investigations, including B-scan, OCT, FFA, carotid Doppler, Humphrey versus Goldman visual field. Now, the management of neovascular glaucoma depends on 4 essential parameters. The first parameter is the underlying etiology. The second is the visual potential, and then the symptoms of the patient, and then last but not least is the clarity of the media. And if we say that the patient presented with no light perception vision, then you have two possibilities. Either the patient is complaining of pain or no pain. If the patient is not complaining of pain or is asymptomatic, you can observe and take care of the other eye. If the patient is complaining of pain, you have to know what is the cause of pain. Is it due to ocular surface disease, microbial keratitis, pseudophakic bullous keratopathy, or is it due to high IOP? And you have to start in a stepwise approach with medical treatment, with topical steroids, atropine, anti-glaucoma medications. And if this didn't help, you can go to external CPC, retrobulbar injections, and enucleation of the eye. If the patient is having a useful vision, then you have to be urgent in your management to preserve the angle and to save the disc. And ideally, the patient should be admitted, the IOP should be controlled, antivascular endothelial growth factor. If there are no systemic or ocular contraindications, you have to treat the cause, most likely PRP, and then topical steroids and atropine for inflammation and pain. And surgical management of glaucoma is usually required with tube, trap, or cyclophotocoagulation. In conclusion, you have to examine the retina very well before any intervention. And after an intervention, you have to be even more careful to detect any retinal signs of ischemia or diabetic retinopathy or proliferative diabetic retinopathy. And you have to know that antivascular endothelial growth factors are not the definitive treatment of neovascular glaucoma. However, they help to regress the vascularization more rapidly, and they give a window for the definitive treatment to be instituted. Thank you very much.
Thank you, Tariq, for a very nice presentation you did. طبعا patient he came to the hospital, to business clinic, with history of laser and injection. When examined by retina people, there is no laser marks at all. But he took injection. In spite of injection he took, he came with rubeosis. This can explain you that injection is not the treatment of neovascular glaucoma. It is just help, but not the main treatment of neovascular glaucoma. The main treatment is to do full, not even PRP, full pan-retinal photocoagulation. I mean not scattered laser in the retina, because this will definitely regress the rubeosis not to appear again. So what is the benefit of anti-VEGF? Again, yes, this is an important point, because sometimes you have full synechial angle, but under the synechia, the trabecular meshwork is function. ساعات تبقى السينيكيا عالية شوية, high synechia. So if you regress this new vessel and the angle, sometimes you save parts of the angle which help for future glaucoma surgery. Tube or trap, whatever you do. And you want to save some area of the angle with function trabecular meshwork. Whatever surgery you do after that. You want to do trap or tube? And in phakic eye, I like to do trap. In pseudophakic, I like to do tube surgery. Yeah, I have one case actually came to me from King Faisal Hospital, Filipina nurse, with neovascular glaucoma and pupillary block. طبعا انت هتعمل لها بي اي, this is red line, يعني معناه ان انت if you do PI, this is a problem. You want to release the pupillary block. No. You inject Avastin, you do PRP if you can, as you can. During surgery, I release the pupillary block actually. During surgery, I did surgical iridotomy with tube surgery. But if you try to do PI, you will go to the hell. يعني. It may be severe bleeding, you cannot stop. So until you prepare the patient for surgery, you can release the pupillary block during surgery, better. But don't try to do laser iridotomy in this patient. How you can do argon to coagulate the vessel and do like in uveitic patient, but in neovascular glaucoma, you don't know what happened. If you touch the iris, it will be severe bleeding. Anyway, you will operate the patient within 5 days after now of Avastin. Before we are waiting 2 weeks to operate. Now because we give Avastin, we can operate within 5 days. The rubeosis usually disappear. Then you can go inside and release the pupillary block. Better, because when surgery you are putting viscoelastic, you can stop the bleeding. But with laser, what you will do? You will go to another problem. If poor visual potential, I don't advise to go for major surgery like tube or trap. Do CBC. If no visual potential, if poor visual potential. Yes, you should do. You should not leave even light perception. We never see sympathetic Osama, حقيقة يعني. I never see from CBC till now يعني. How many years you are working, we never see this. إنما why to do tube surgery for light perception أو query أو poor, very poor vision? لا, poor visual potential, not poor vision. Because you know universal glaucoma is secondary glaucoma. يعني maybe the patient will come with light perception and improve to 20-30 vision. إنما احنا بنقول potential, that means he have damaged disc ischemic retina. Like this patient, he has ischemic retina. يعني البيشنت came to you with phakomorphic tomb تعمل له dilatation. What do you want from the view? انت you want to clear, you want to get the pressure down. مالك بالفيو؟ No one will dilate a patient of angle closure glaucoma or phaco. No one will dilate. This is contraindicated. انت your aim to get the pressure down and you get the inflammation down. You do PI then dilate. شالوا AC should not dilate. ودي مشاكل الريتنا. طبعا احنا عارفين الريتنا patient will enter the clinic dilated من بره من nurses. This is wrong approach. This is wrong. The patient should be examined before you put dilating drops. طبعا بعض الناس he is correct. بعض الفيكومورفيك you do everything and the pressure is not down. You should take him. هذا ما لي حل غير take the patient for surgery and do gradual decompression of the globe. Don't make sudden decompression because you may get problems. Suprachoroidal. Take the pressure out gradually by the super sharp in surgery until the pressure become quiet. Then you can do طبعا trap, cataract plus minus glaucoma surgery according to duration, gonioscopy and the medications. طبعا احنا الستادي we did a study about full BRV and the success rate of trabeculectomy in neovascular glaucoma. لقينا ان تقريبا 10 days 10 to 2 weeks هو التايم to go for surgery until rebuses disappear. طبعا this is before Avastin. الكلام ده كان من 20 سنه الاستادي احنا ببلش. انما الحين في Avastin you can operate after 5 days. But don't operate if you don't do BRV. ما يضحكش عليك الريتنا ويقول لك خلاص النوروبيوزس قول له كمل البي ار بي قبل ما اشتغل. Take care of this point because some retina people they give the Avastin and they give you not all full BRB. يعني يعمل شويه يقول لك هكمل بعدها، ما يكمل بعد العمليه because the patient will have surgery, very difficult to touch him, very difficult to continue BRB. Don't touch the patient except he finish the laser treatment. This is my advice. اتفضل يا أمي.
Good afternoon, everyone. So I'll be presenting the second case for our morbidity and mortality meeting today, titled, Doctor, Do I Have a Brain Tumor? I would like to thank Prof. Issam for providing me with this case and for his kind and very keen supervision. So around 2 weeks ago, we received a 30-year-old, very anxious Saudi lady who presented to our emergency room at King Abdulaziz University Hospital with a referral from a private center stating that she needs an urgent MRI as she's having a rapid relative afferent pupillary defect in her left eye. The patient was so worried as she was told that one of the differentials is a brain mass, and she was advised therefore to have an MRI as soon as possible. So upon further history taking from the patient, she reported that she had history of mild gradual change in vision in her left eye over the past year, which was associated with throbbing headache, localized mainly to the left side, and it improves on applying pressure. This headache occurred also with left eye pain. She had no history of any other visual symptoms. She had no history of nausea, vomiting, early morning headache, or other neurological symptoms. She had no family history of glaucoma and no history of previous steroid use, whether topically or systemically. So her past ocular history was significant for refractive surgery, LASIK, in both eyes 16 years ago. And the patient initially denied any previous history of trauma. However, after asking her 4 times, she mentioned that she had a significant eye trauma. She was not sure, was it the right eye, left eye? Probably it was the right eye around more than 26 years ago when she was 10 years. Her past medical history, surgical history, and drug history were unremarkable. So on examination, her vision was 20/20 in both eyes. The IOP was 15 in the left eye, and it was 26 in the left eye by Goldman applanation. And we should all don't forget that she already underwent refractive surgery, so this is underestimated.
Go back, man. Don't forget to mention relative affirmability effect,
yeah.
please.
It's mentioned here. So this actually IOP is underestimated as she already underwent refractive surgery previously by around 3 to 4 millimeters. The extraocular motility was full, the pupil was regular reactive and round in both eyes. However, we noted that she had a trace to +1 relative afferent pupillary defect in the left eye that she was complaining of. The red reflex was bright and symmetrical, and the colored vision was equal and full in both eyes. Slit lamp examination of the anterior segment was unremarkable for any pathologies in both eyes. Fundoscopy of the right eye showed a healthy optic nerve with a cup disc ratio of 0.4, a healthy neuroretinal rim. However, fundoscopy of the left eye showed cupping, where the cup disc ratio was around 0.75 to 0.8 with inferior thinning. I apologize for the quality of the picture, but it was taken without dilation.
هل كلير ولا ما كلير؟ واضح ان في advanced disc damage.
Yeah, you see that she's having cupping.
بس كلير يعني.
Yeah. So she has here, as you can see, also inferior thinning of the neuroretinal rim. هذه after the modification of the picture.
لا والله كتير كويس.
So we did for her gonioscopy. In the right eye, it was an open angle in all 4 quadrants with no problems. However, in the left eye, as you can see here, she has a wide ciliary body band with a very white glistening scleral spur in more than 2 quadrants, actually in the temporal and inferior quadrant, so more than 180 degrees. So we sent her for investigations. We did central corneal thickness, which was 479 microns in the right eye, 483 microns in the left eye due to the refractive surgery. We did OCT and NFA and ganglion cell count in both eyes. It was normal in the right eye, and this is the left eye. We can see that there is thinning of the nerve fiber layer superiorly and inferiorly, and there is loss of the ganglion cells. We also did visual field 24-2, but however it was unreliable even when we repeated it. So also we sent her for UBM, and when she came back, the report of the ultrasonographer was that it is negative for angle recession. However, here, looking at the photo, you can see that, similar to what Dr. Faisal explained to us earlier today, there is a widely exposed here ciliary body, and the iris insertion is pushed posteriorly, so here it is evident that we have angle recession. So the diagnosis at this point was angle recession glaucoma in the left eye, so she was started on topical anti-glaucoma medications, Cozopt, BID, and her IOP was controlled on follow-up. It was 15 millimeters mercury. However, since the patient was so anxious and she was so preoccupied that she has a brain tumor, she insisted on having an MRI, so she went to private, she paid from her own pocket.
How she insist? From herself or somebody advised her?
No, she was already advised, and she was, very anxious.
Actually, she is advised by the private doctor in private hospital that she has something in her brain, she should do MRI.
Yeah. So even after I reassured her that this is glaucoma and this is the cause of the APD and cupping, she still went and she had the
But he was
MRI.
ophthalmologist who advised or non-ophthalmologist?
Ophthalmologist,
Good.
yeah. And she actually paid for it from her own pocket. She has no insurance, and she came back within less than a week to the clinic of Prof. Issam with the MRI report stating that the MRI is unremarkable for any brain pathologies. So I'll go briefly over angle recession glaucoma. As we all know that it's a secondary open angle glaucoma that usually develops after blunt eye trauma. And angle recession was first described more than 100 years ago by Collins in 1892. And studies have shown that a small percentage of these patients, they go on to develop glaucomatous optic neuropathy and vision loss days, months, or even years later. And actually the longest reported period for the onset of angle recession after trauma is 50 years. And most of these patients, actually, they don't recall history of trauma, or they might tell you, as our patient, that trauma maybe was in the other eye because it occurred when they were very young. Several studies have shown that the greater the number of clock hours of angle recession, the more likely that the patient will develop glaucoma. And most studies confirm that more than 180 degrees of angle recession makes glaucoma more likely as an MR patient. And one study reported, interestingly, that 50% of angle recession patients will actually develop open angle glaucoma in the contralateral eye. And why is that? Does anyone know? Yeah, predisposition. So yeah, the hypothesis is that angle recession is not the only cause for the high IOP, but it actually accelerated the damage in an eye which is already at risk for glaucoma, and that's why the other eye is at 50% risk of developing open angle glaucoma. So the pathophysiology, when the eye is exposed to trauma, there is shortening of the anteroposterior diameter of the eye. This will force the aqueous humor laterally and posteriorly, pushing the iris and the angle posteriorly, causing a tear between the longitudinal and circular muscles of the ciliary body. This might also result in rupture of the ciliary arteries, resulting in hyphema. And therefore, patients with blunt trauma presenting with hyphema are more likely to have angle recession than those presenting with blunt trauma and no hyphema. Initially, these patients might develop IOP immediately after the trauma, and this is usually because of the direct damage to the trabecular meshwork, Schlemm's canal, in addition to the contribution of hyphema, if present. However, later on, years later or months later, when they develop glaucoma, the cause is usually fibrosis of the trabecular meshwork and Schlemm's canal, in addition to a hyaline membrane that has been reported to grow across the trabecular meshwork. So the diagnosis of angle recession glaucoma is usually made on a clinical basis, based on history, of course, examination. Don't forget always to do gonioscopy and examine the other eye, very importantly, because if there is 360 degrees recession, you might miss it if you don't compare to the other eye, in addition to looking for signs of previous trauma, such as a Vossius ring or ruptured sphincter. So the differential diagnosis of a unilateral glaucoma includes steroid-induced glaucoma, uveitic glaucoma, neovascular glaucoma, less likely carotid cavernous fistula, uveitis glaucoma, hyphema syndrome, and of course the asymmetric glaucoma such as pseudoexfoliation or pigmentary glaucoma. The management, usually as any other glaucoma, we start with medical management with topical aqueous suppressants. If the patient does not respond, then we're going to go for surgery. So now I'll move to the second part of this presentation, and this is the main aim of this presentation, is how to differentiate between glaucomatous versus non-glaucomatous disc cupping, and when do you need to neuroimage your patient. So actually distinguishing between both is not very easy. It can be challenging even for experts, especially if the IOP is normal. In our case, the IOP was elevated. This was a very good hint that this is most likely glaucoma, but in some patients like normal tension glaucoma, the IOP is usually normal, which may make it more difficult. Pathological optic disc cupping is most commonly caused by glaucoma. However, other neuroophthalmic conditions and less commonly retinal conditions might also cause cupping. And actually, previous studies have indicated that around 20% of patients with cupping due to a neuroophthalmic disease were misdiagnosed initially with glaucoma. So the conditions that can cause optic disc cupping, of course, other than glaucoma, include compressive optic neuropathy, retrobulbar neuritis, Leber's hereditary optic neuropathy, toxic optic neuropathy due to methanol or drugs such as ethambutol, CRAO, and ischemic optic neuropathy. So what are the warning signs that we need to look for in history, examination, and investigations that might give us a hint that this patient something serious and we need to neuroimage? So young patients, now we know that glaucoma is more common in elderly or older patients. It's less common in young. So when you have a young patient and you have an APD and you don't find an ocular cause on history or examination suggesting or explaining this APD, then it's better to image the patient so that not to miss anything serious. In addition to symptoms, especially if there are neurological symptoms such as early morning headache, nausea, and vomiting, other neurological symptoms or motility defects, then it's better to go and image the patient. Any patient with atypical findings, whether in the history, examination, investigations, it's also better to go and image the patient just to make sure that there is nothing serious. The optic nerve examination and the optic nerve function is extremely important. So the visual acuity, as we all know that in glaucoma, usually the visual acuity is preserved until later in the course of the disease, in comparison to neurological causes where visual acuity is usually severely affected from the start. Visual field is usually severely affected from the start, unlike glaucoma. And it's very important to correlate the visual field, the visual acuity, with the cup disc ratio. So usually in glaucoma, when we have advanced cupping, or very severe cupping, it's not until then the visual acuity and visual field will be affected significantly. But in patients with a neurological disease, the cup-disc ratio might be mild, or there is mild cupping. However, there is significant affection of visual acuity and visual field. The timing of cupping is very important as well. In glaucoma, usually cupping develops, then we will have the visual field defect, while in neurological disease, usually we have visual field loss, decreased in visual acuity, and then cupping develops later on. The optic nerve frame color is extremely important. Whenever there is pallor of the neuroretinal rim and pallor is more than cupping, then you need to consider neurological causes. However, in glaucoma, usually the rim color is preserved. It's usually pinkish until very advanced glaucoma. It's not until then when the rim becomes pale. A relative afferent pupillary defect in a patient who does not have asymmetric cup or field. Our patient had already an asymmetric cup and field, which explained her glaucoma. But if you don't have an asymmetric cup or field and you have an APD, it's better to go and image the patient to rule out other causes. Color vision defects. Glaucoma might affect color vision. However, in neurological diseases, they usually affect colored vision very significantly. Visual field, which is not typical for glaucoma, such as a central or a sequocentric scotoma, bitemporal hemianopia, defects respecting the vertical midline, inferior altitudinal defects, visual field loss, which is not proportional to the optic disc cupping, then you need to consider imaging the patient. These are usually not explained by glaucoma. So this is a table that summarizes the differences between glaucomatous cupping and non-glaucomatous cupping. As we mentioned that the neuroretinal rim is usually pinkish in glaucoma, while it's usually pale in non-glaucomatous cupping. The loss of the neuroretinal rim tends to be focal, especially early in the course of the disease in glaucoma. Might be diffuse. It tends to be diffuse in non-glaucomatous cupping. Cupping is usually seen before visual field defects and before vision loss in glaucomatous cupping, and it correlates to the cup-disc ratio. While in non-glaucomatous cupping, cupping is usually seen after visual field defect and vision loss, and it usually marginally correlates with the visual field defect and disc changes. IOP in glaucoma might be high, such as in our patients, or it might be normal, as in normal tension glaucoma. In non-glaucomatous cupping, it is usually normal. Visual acuity is maintained in glaucoma until later in the course of the disease, while it's affected significantly in non-glaucomatous cupping early in the course of the disease. Peripapillary atrophy is very common with glaucoma, and it is very uncommon in non-glaucomatous cupping. So to conclude, always keep in mind that glaucoma is a cause of a relative afferent pupillary defect, especially advanced glaucoma. Approaches to distinguish glaucomatous from non-glaucomatous causes of optic disc cupping should rely on patient history, visual field assessment, and fundoscopic findings, and always correlate all these together to explain for you the presentation. Whenever you are in doubt, just go and image the patient so that not to miss anything serious. However, if you have a clear cause, like in our patient, there was a clear cause, clear glaucoma, there is no need to stress the patient, make the patient just pay for expensive tests for nothing. Thank you.
Thank you, Iman, for your nice presentation. ايه المسج بقى حق الحالة دي؟ يعني اللي فاتت عرفنا المريض راح البرايفت ما عملوش بي ار بي. بس عمال ياخد انجكشن افاسن he came to with 50%. This case, what is the message here? طبعا انتوا ما شاء الله فيكم ناس بعد سنه هيبقى فيلو، بعد سنتين هيبقى كونسلتنت، هيروح يشتغل في البرايفت. المسج هنا تخلي فلوسك حلال. لازم مالك يكون حلال. patient with high pressure, disc cupping, high cup مش cupping عادي يعني 0.8 تقريبا مش كده؟ And definitely there is unilateral glaucoma here. Why to image the patient and you tell him you may have brain tumor? فدي very important image ان انا ممكن اكسب كويس جدا بس حلال مش حرام. يعني تقول ايه المشكله لما اعمل له؟ لا مشكله. When you advise the patient wrongly, this is not ethics. يعني ما هي الشطاره ان انت advise some investigation unnecessary. بعض الناس يقول لك طب انا اعمل له احتياطي، احتياطي ايه؟ عندك very clear as Iman mentioned very clear diagnosis. Maybe even if they forget to measure they didn't measure intraocular او البريشر طلع نورمال معاهم. الاي بي دي with disc cupping, this is glaucoma. The most common cause of optic neuropathy is glaucoma. You have anyone have comment here in this patient? لا اتكلم. زياد عمال يصور. Any comment يا ايمان؟ If no more question, thank you very much. الجمعة مين بتأجلت يا جماعة الأسبوع الجاي؟
جدة ولا وين؟
الجمعة دي في البداية هيجيلنا الدراسة المفروض اليوم اتأجلت الأسبوع الجاي. بس بين يا إمام عارفة فين المكان؟